So I'd ask all our presenters to take the seat, and we're also invite our esteemed, distinguished co-chair, Lynn, to join us on the table too. And I know she needs to leave maybe a little bit early, so we'll try to catch up as fast as we can. So the lessons so far I've learned is, eat whatever you want to eat, but you're going to be doomed anyway. Physical exercise is not going to help. You're going to die one day. And then action is overrated, because if you take action and intervention, you might not get anywhere. All right. So let's get to the real scientific stuff now again, to our panel. And we'll start with the questions. Erin?
Sure. This is a question from the web. This is Janet Young. So she notes that Dr. Lekine spoke on inconsistencies in the chemical studies. And she notes that in 2009, Chemical and Engineering News reported that gut bacteria influence the toxicity and effectiveness of pharmaceuticals. So her question is, wouldn't the individual gut microbiome signature affect the toxicity of exogenous chemicals and therefore research outcomes?
Judy?
Yeah, so that's an area that I don't work in, so I can't speak to that directly, but what I can tell you is that, as I alluded to before, there are probably, 200 things that are affecting the levels that are seen and the outcomes that are seen. And one of the problems that we have with our current database is that most of our studies are cross-sectional. So we're looking at the presence of a chemical that the person was exposed to at most the day before, and trying to look for associations with chronic illnesses that probably began decades prior. And so it wouldn't surprise me at all if something like the microbiome was at play here, along with, like I said, 100 other factors, and that would be at least partially explanatory in terms of why we're seeing such a mess with the totality of the results from this literature base.
Folks, yeah, Lynn, please.
I really have to agree with Judy, having reviewed a lot of these studies myself, and that is that the exposures you really want to know about, which are the exposures that have occurred over sometimes decades or prenatally in the case of a child, are not the exposures that you can measure. You're measuring more immediate, short-term exposures, and you don't have that sense of kind of the cumulative burden, because most of the things we're concerned about today don't have long half-lives, have fairly short half-lives.
Linda?
So, Judy, I think I want to thank you also for your pointing out the problem of many of the human epi studies on the short-lived chemicals, which are often based, even if they're longitudinal, are sometimes based on a single spot urine. I mean, the whole NHANES database, which of course is cross-sectional, is single spot urines. And we know that for some of the short-lived chemicals, that can be completely misleading. There's some data that says with some of the phthalates that the correlation between multiple samples is not, between the higher molecular weight phthalates, is not as bad as some of the lower molecular weight phthalates. And again, I'm speaking about the metabolites. But we know there are some studies now that show, as for example, for BPA, you may need at least 4 to 7 urinary measurements to have any idea of what at least the average urine may be. And since in many cases we don't know whether it's the area under the curve or the peak concentration that may be important, that's another confounder or problem.
Sheila?
Yeah, so although I do think the exposure assessment is a difficulty in epidemiologic studies of chemicals with short half-lives, I do think that there's a lot of data out there on the multiple exposure time points and what they're reflective of. And I agree that the high molecular weight phthalates are a little more reliable than some of the other chemicals. But I will say, from having worked in this area for several years now, that the highest exposure concentrations for a lot of these chemicals, because they're in the diet, is at night. It's usually after an entire day of eating. And when we do our studies now, we ask our study participants to get samples at night. But when you look at NHANES or most of the epidemiologic studies, none of those samples are from nighttime. They're during the day. So if I had to guess, those exposure estimates are very underestimating, or they're underestimating the actual burden, body burden that an individual is having. But for those of us who can, we are trying to do 24-hour exposure assessment. It is very difficult to ask a study participant to collect all their urine over a day. Even if we all had to do that today, it would be really hard.
This is Judy. Can I interject one comment?
Yes, please.
I would just also mention, in terms of reliability and stability of exposure data, I don't know, I'll just use an anecdote. I can say for sure that my diet today is nothing like the diet that I experienced when I was a kid. I mean, I haven't had a Twinkie in, 45 years. Or longer, maybe. And so, again, if we're talking about chronic disease, it may be that, okay, maybe we can understand what's happening with these chemical exposures over the course of a few days based on a measurement, or maybe even we can stretch it out just a little further, but I seriously doubt we can stretch back to windows of exposure that we're probably really interested in. We're going to have to design a different kind of study for that.
Thank you. Dennis?
Yeah, Dennis Devlin, ExxonMobil, roundtable member. I want to address the issue of TSCA. It's come up a couple of times, and the the new piece of legislation, which actually the Senate is going to drop in a couple of weeks. There's a new draft that'll be coming out soon. And I also am on a small group from industry that has been engaged with the NGOs and the Senate staff in trying to come up with a reasonable alternative to TSCA, which certainly, absolutely is necessary. One of the concerns we have, and Dr. Conry actually had on one of her slides, that our organization strongly supports legislation that shows that chemicals are safe for human use, and shifting the burden on industry to provide the information for that, which is certainly appropriate, and I think all of industry agrees with that. But I want to get to the point about showing that chemicals are safe for human use. Now, we're talking about industrial chemicals. One of the concerns we have is that that's going to be very difficult for EPA to do. And I wish I had somebody on the EPA panel to answer this, and maybe Al or somebody from the audience could, but I'll throw it to Lynn first, because I think you're very familiar with the culture there. It just seems, while FDA, for example, their culture is one where they are willing to say that something is safe for its use. For industrial chemicals, with the myriad of exposures and uses, it seems that that's going to be a very difficult thing for EPA to do, to say that a chemical is safe. And this workshop actually points to one of the reasons for that, because the burden would be on EPA to say, yes, this chemical is safe for its intended uses, and then a few years later, you come up with some genuine concern about a new outcome, obesity for one, and who knows what it's going to be in a couple of years. So what do you think? What about our assumption that that is going to take a tremendous cultural change at EPA, and it's going to be very difficult?
So I think most of you are aware that at one time I was an assistant administrator at EPA, and I was responsible for the TSCA program along with FIFRA and pesticides. And I do think that EPA is capable of making judgments about specific uses and categories of uses, does under TSCA all the time. And so actually there are decisions that are made, for example, about when a chemical shows up that has ecotoxicity, that it can't be dumped into water. And, this will be done with a significant new use rule, that chemical cannot be discharged into water, or that it must be, they will do things like require protective gloves if there's thermal absorption of the chemical and certain occupational settings. And so, and then when you get to the pesticide program, every single use is specifically approved by the EPA, every single use. And they have more data. They have more data, but they have a suite of chemicals that are created intentionally to be bioactive, right? So it's whereas under the industrial chemicals world, not all those chemicals are bioactive. And so the real challenge there is for EPA to identify the chemicals that are likely to be bioactive, and give a lot more attention to those and the intended uses of those, and or the ones that are being found in people, in the newborns and so forth, and or the ones that are going to be going over to FDA to be used for food containers, infant formula bottles, and things like that. Of course, we all want to have those scrutinized more carefully. So it's almost like common sense that you can actually, if you may, filter out from the thousands of things that one might look at, the things that really are most important to look at. But then, is it possible that judgment will change? Well, I hope so. Because, science moves onward and things do change. And so I think that's important. There are one or two other things I wanted to say. And that is that I think that some of the policy discussions that we've been having, EPA is right in the center of a lot of that because of how many of these things that we've been talking about, whether it's bisphenol A or phthalates, are industrial chemicals. But I think it's very clear that the FDA is a part of this picture in terms of, because the EPA, if the use is for food additive, or any other regulated entity by the FDA, EPA is not allowed to regulate that use. And so the capacity of FDA to be able to scrutinize those, and if you may, the willingness of FDA to use its authority to look at those is extremely important. Reforming TSCA is kind of a necessary condition, but it's not sufficient. It's not enough. You also have to have, attention by the FDA in these things. And then, I also think that the private sector has a major role to play in all of this. And we've already been seeing not only, how market demand can influence things like the availability of BPA in food containers, but I think we've also seen many corporations on their own moving away from some of these substances. Johnson & Johnson took the formaldehyde out of baby shampoo without any order from EPA, just did it. And I don't think that we should at all underestimate the power of, with the Reform Chemicals Law and more information being made available to the public and to corporations, that many of these would change without rulemaking. They've changed because, if you're looking at it and say, well, do I want formaldehyde on my baby's head? My answer would be no, and most people do feel that way. And so I think some of these changes, a necessary condition that they're occurring is identifying where substances are in use in the marketplace and what the potential hazards of them are. And those data gaps about use and hazard are making it very difficult for those who want to do the right thing to actually be able to.
Go ahead, Sheila.
One comment to your comment. I think that while EPA doesn't necessarily have a lot of health experts, they have a lot of FACAs. And so the federal advisory committees who can advise on intended uses, whether it's health-related or not. And so I do think, and Gina McCarthy has referred to EPA as a public health agency several times since.
Let me be clear. I didn't mean they didn't have the expertise.
Mike.
Yeah, or you could come and use it.
I'll just do this. Well, I didn't at all mean they didn't have the expertise. They certainly could. It's putting a tremendous onus on them to say for thousands of uses of chemicals, not just a pesticide for, plant application, but to make them make that judgment that it is safe for that use. That's a tremendous responsibility. And that was my point, really.
And just to be clear, in the REACH regime, companies provide data and specify the intended use. And so that data, there's a huge data gap there, but the companies are responsible for filling in, for informing the government exactly what the intended uses are. Right now, with new chemicals, a new chemical application comes in with an idea of what it might be used for, but there's never any checking back to see whether or not that ended up being the can lining for all baby formula down the line.
Very good. Frank?
Well, this is in this policy section of our 2 days. It's right that we're talking a lot about TSCA reform because it is the biggest single legislative effort that this community the health community and the environmental community are going to see. And however, it is, because we're going to see it, it means it's a bipartisan effort. And because it is a bipartisan effort in this political climate, it's going to not be, from the health community's point of view, the absolute ideal bill. It's going to have serious flaws. And the health community and the NGO community are going to have to make a decision as to whether it's good enough or not. And I know that there are going to be some NGOs that are going to say no. I mean, I say I know. I mean, I don't know what the bill is going to look like, although I can sort of suspect it. But you just know it's not going to satisfy everybody. But I think one of the things it's going to have some preemption. That is, it's going to, I think, provide that certain state level rules, or probably certain, almost surely certain future state level rules, can't make certain of these tests tougher than the bill itself. Well, you know, if we'd done that, if we had that rule X years ago, we wouldn't have the better rules in California, and I suspect in Washington, than we have in Alabama and Mississippi. I suspect that. I haven't actually done that research. But we're going to have to make decisions like that. And I would just say that having been in the game of politics for a while, it's unlikely, if we don't get a bill this time, we're going to get a bill for another X years. So that taking an imperfect bill and dumping it is probably going to leave us where we are for a very long time.
Thank you, Frank. We have some questions.
So yeah, this is a question from the web, and it's from Enze Witherspoon. She's with the Center for, or the Child's Environmental Health Network, and also a member of the Roundtable. So she says, when it comes to our children, what may be some key messages, if any, that public health and child health policy advocate communities may be able to prioritize and rally around with the goal of reducing some of these exposures and related health outcomes?
Well, I have a wish list of some of the most egregious uses of endocrine disrupting chemicals in consumer products. I'm just going to throw out a couple of my favorite ones for conversation. And I think this issue of PVC medical tubing and also PVC use in food processing, because a lot of the contamination in food happens during the processing stage, is of critical importance. And I think we've reached the point where that should be a no-brainer. And I'd love everybody's help on that. You know, when we talk about designing the perfect study to figure out exactly how much DEHP a newborn in the NICU is getting from the medical tubing, I think, no, let's not do that. Let's do something else instead. Let's get it out. And FDA now has guidance that says these are high-risk populations. And in some cases, you should look for, don't delay treatment, but see if you can find some DEHP-free medical tubing for these preemies. And I think, no, I think we have enough information there. And the changes in the marketplace could also really lower DEHP content of food. So I see Linda wants to talk, and maybe I'll stop at my wish list.
Well, I just wanted to make a comment about the DEHP, and for example, in tubing used in neonatal, you know, you have a real risk-benefit ratio here, for one thing, you know, because if you don't treat the neonate, the child may not survive. And the other thing is we've got to be really careful of what we use as substitutes, because we're learning in multiple examples that we move from something that we know has concerning properties to something else because we don't know anything about it. And then when we start to study it, we find it has more concerning properties. So, you know, we've always got to step back and ask the question, what do we really need here?
Right.
You know, we all too often don't ask that question. And I think, yes, you're going to need some kind of tubing in a neonatal intensive care nursery, but maybe there are parts of the tubing that could be replaced by stainless steel and only where you have to have bends. I mean, there may be certain opportunities that could be looked at there to reduce the use of plastics in general. But I think we've got to be really careful to just say, let's substitute something else. So I'm just going to put a plug in. There's a 2-day meeting happening at NIH, the Natcher Center, Thursday and Friday, on alternatives assessment. And, you know, so that you basically look more broadly at what you are going to use before you jump into it.
Sure.
Lynn? Yes, please.
I just wanted to add a point to Nsei's question in terms of advice for parents, which is, I think, to take control over several aspects of this issue. One, what your kids are exposed to in the way of advertisements. The Saturday morning ads for junk food and for all kinds of bad things that kids are very susceptible to. Studies have shown that young children are not critical about advertising messages. The second thing I think they need to take control over is what the children are being served at the school, and that many parents are engaged with that, getting the sodas out, the junk food out, and supporting the USDA and serving fresh fruits and vegetables, good food in the school lunches. There's a huge political movement to undermine the USDA's efforts to do this, the so-called lunch ladies that are going to Washington and saying that, you know, kids will only eat junk, and that's not true. The studies don't show that, and parents need to be engaged, or this will be reversed, and we will lose this. And as well as taking more control over what kids are eating at home. And some of these, my colleagues here have already mentioned some of the things that they do with their own children. And I think that that's a real indicator when you have, you know, young pediatricians who are parents who are saying, you know, we're using glass and stainless steel, we're not using plastic bottles. Parents just need to become aware of these things and make choices that are more sensible. Or as one of my relatives who works at the FDA tells me, that his rule of thumb is, if the FDA needs to decide that something is a food, it's not a food. Anyway.
Yeah, so also I just wanted to say that in terms of reassurance to parents, because I talk to a lot of pregnant women who are very scared of the world of toxic chemicals that we're exposed to. So one of the things I tried to say is that we're not going to get to zero. There's no way to get to zero, unfortunately, in the world that we live in. But that there are things that you can do to reduce exposures that we do know, that there is evidence for. And so something as simple as taking your shoes off at the door, or keeping the carpets clean, keeping your floors clean, that does reduce exposures that are associated with some of the health outcomes that we've talked about over the past day and a half.
Thank you, Sheila. Let's go back to the question.
Yeah, Henry Anderson, roundtable member. I just wanted to follow up on that on the exposure assessment side. I think in all of the studies we heard in the last day and a half have dealt with biomonitoring, and then we know many of these are short lasting compounds, and so we sort of say, well, we know that this really isn't a good measure of what it is, but it's the best we got. And where I would head and think on the policy side as well is we really need to look at source apportionment. I mean, you look at FIFRA where they add up, you can only have so much on bananas and so much on this or that. I think we really need to look if the source of the exposure isn't drinking water. I mean, we got pretty good drinking water data, but it's in the diet. If you look at how the nutrition people do it, it isn't by measuring all of the vitamins in the biomonitoring sample. It's looking at what's in the food. And I think from the public standpoint, it's very helpful to know that do they need to worry about eating canned food, or do they need to worry because most exposure is coming from food that's put in plastic containers that are near the end date for their shelf life because the food has been attached or connected with it for several days. So I think it would be helpful to get a sense of where the exposures for the very specific chemicals are coming from. I think your app of being able to go and look at a can and see this one is providing so much sugar versus that. I think all of those are good things. But on the chemical side, I don't think we spend as much time looking at the next phase of exposure, which is looking at the source apportionment. And then, the public, I think, like with fish, if you know what the species is you're buying, you can know what the level of mercury is, and then you can compare them. You should be able to do that with some of the other products, I would hope.
Thank you, Henry. In the interest of being inclusive of our participants online, I'm going to suggest to both of you, Judy and Jean, if you have a comment or a question, jump in right up front. Otherwise, we might keep on spending time here in person. Do you have any response to or comments so far? Judy, you first.
Can I respond to the last comment that
Certainly.
was made? I think it was a really important point, and I think for those of us with a history of risk assessment and exposure science, in the early stages of this field, most of the focus was on measurements in media. So if we wanted to understand risk from a chemical, we would grab samples of soil and water and food and air and measure chemicals and try to look at combined intakes and get a sense of dose. And then when biomonitoring came along, it became, and it's often referred to as the gold standard for exposure science. And in a sense it is. It tells us all of the routes and sources of exposure, so we know we're not missing anything. But what we lose is exactly what you're talking about, source apportionment. And so we've devoted a lot of resources to developing large databases for biomonitoring, much of which, well, I'm not going to give a percentage, but some large portion of which we really don't know how to interpret. And I think that while the traditional methods for exposure science might feel to some people to be less exciting because they're older, I still think they're extremely important.
Thank you. Jean, do you have any comments or thoughts so far?
My comments were along the same lines. I think, when we're looking at the broad picture and looking at what women are being exposed to, certainly with their pregnancy, the number one issue for us in terms of women's health outcomes in pregnancy would be gestational diabetes and how that impacts the health of a pregnancy. So all OBGYNs take these kind of discussions on the elements that impact obesity to heart, but then we step back a step and look at diabetes itself and that as the overriding impact for pregnancy outcomes.
Comments on here?
I guess I just wanted to highlight the complexity of your question. It's not it's not as simple as sample apportionment, and because first of all, manufacturers change formulations constantly. We see these in personal care products, and when we test one product one year, it has a different concentration than the next year, although it's the same exact product. And so they change their formulations constantly, and they're not necessarily disclosing those changes, and they don't need to. And then in terms of foods, it's the same. Sometimes their process, if you think about these chemicals as contaminants, sometimes their processing changes over time. And if the chemical's a contaminant and it's not even part of the food product, we can't even predict what could be the exposure from a specific sample of food. So for the phthalates, there's been a lot of studies done on what sources are, and that's why I can pretty confidently say it's diet, but for many chemicals there's not. Some phthalates, yes, thank you.
I mean, I would agree with you. I think that house does as well. Yes. It's if you want to get to the fire retardants.
All right. Yes, please.
Linda McCauley, member of the Round Table, and I want to thank IOM for this wonderful 2 days and recognize that we have a very biased view. We either are here because we're passionate about environmental health or we're passionate about obesity and healthy lifestyles. But when I leave here, I'll go back into an environment full of healthcare providers. And I think we all know that probably environmental health and environmental education is the stepchild of medical and nursing and health provider education, probably nutrition is right after that. It's neglected in curricula. And so here we have an epidemic where the potential causative factors that we've been discussing for 2 days are things that are not of high priority in our educational systems. And I think we need to do some serious work there because we cannot wait until we answer all these very interesting questions around the science. Our practitioners, our public health workforce need to be talking to the public about things that they can do. When you only have 10 minutes with a client, tell me how you distill what we've been talking about into maybe a 3-minute interaction with the families, and it's hugely important. And I wondered if some of the clinicians in the audience might speak to those challenges.
This is Jean Connery.
Go for it, Jean.
Yeah, I mean, I think that's a very valid concern and very much one of the concerns that we always have. As an organization, we have tackled it in different ways. Our annual clinical meeting last year had the presidential address was on reproductive health and the environment, and we had a series of keynote speakers and other lecturers who provided information for the fellows. We are working with our board certification to provide articles for physicians to read in terms of their board certification so that they are exposed and understand some of this. So I think you have to look at it incrementally. What are we doing for our board certification? What are we doing for education of medical students? And what are we doing for education of residents? And then finally, the other thing that ACOG is working on is we are collaborating with the International Federation of Obstetricians and Gynecologists for a statement on reproductive health and the environment, and are having a symposium in October for the annual meeting, international annual meeting on this topic. So I think there are a number of different ways we're trying to get it, but it's incremental without a doubt.
Yeah.
So I spoke to it a little bit before, but let's just take a scenario of like that I do see in clinic. I work in a public health clinic, a 5-year-old who's obese, who's coming to clinic, and I probably have half an hour with them, or I have 5 minutes with the resident who has a half an hour with them. So I, first talk about the growth curve, making sure the parents understand what's going on with obesity when the child is gaining weight at a more rapid rate, make sure they understand what obesity is, why it's important, what it can lead to, then talk about their diet. And although we don't want to stigmatize these kids, I would actually disagree a little bit about that in a counseling setting, because I think you'd be surprised at what families are eating and drinking. I did have a 5-year-old family where that family was consuming 2 liters of soda every week, the entire family together. And that's something that's an easy target. So I do that. And then I go into other things within the home that they can do to keep their child safe and reduce exposures. So that's my prioritization.
And, it really aligns well with the whole area focus on healthy communities and prevention. And school nurses are predicted to play a critical role in healthy communities. And they do have a lot of stigma when they contact parents about the weight of children and fight a lot of opposition to changing the vending machines. And it's hard work. It's hard policy work on the ground that some of our care providers are doing.
So I will add a comment here, because I'm also an internist, and although I don't do a lot of practice nowadays, I have lots of friends, and just a few weeks ago I asked a question to about 8 or 10 internists and about 6 or 7 family practitioners. We were together at a dinner, and I said, of the patients that come to you, of the folks that come to you, what percentage of folks would you think would be overweight or obese? And they said 60-70%. Yeah? Nope, so it's same as the background population. The next question I asked was, how many of those people come to you for obesity? You know what the answer was? 1 out of 17. Now, that is where the problem lies, because obesity or overweight is no more an anomaly. That's the usual. We are always worried about the unusual. This has become the usual. So people are coming in for other medical diagnoses, but not for the underlying cause of those medical diagnoses. The next question I asked them was, do you have a code that you can put to get reimbursement for the time that you spent talking about obesity? And most of them said, well, we could do something with it, but we'd rather put a diagnostic code. So that's it. Just an editorial comment from my side. Please go ahead.
Just one quick comment. If you don't want to use the word obesity, one of my old clinic mentors used to use the word malnutrition, which I thought was a really nice term with families that she felt uncomfortable saying the word obesity to, and I do think that there is a big component of malnutrition there. So
good point. Good point. Lynn? Any other thoughts or questions? Well, we are a few minutes before our time, which may be very appropriate for people, but I just wanted to ask one more question. We're talking about environmental and health policy. How about other social policies that have a significant potential contribution to the environmental health, and in this case, particularly as we are talking about obesity? I think Linda or someone else also brought up the issue of Europe and how there is a maternity leave that extends up to a year. There's a paternity leave that extends up to 6 months, both paid in most instances in many parts of Western Europe. And then there are additional periods of time in terms of part-time work that mothers or fathers can do, and which is an acceptable social and business behavior. Yeah? All of those have some contribution, not just with this, but others. So those are social policies that have direct or indirect implication on who prepares food and who manages people. Then?
I think those are all really excellent examples. I'd also hearken back to our urban environmental health meeting that we had a few months ago, and some of the conversations about, for example, as they're rebuilding the areas around Connecticut, New York, and New Jersey post-Hurricane Sandy, and reshaping those communities, creating communities that are much more walkable, that promote physical activity. In one case, connecting the community actually to the wholesale food markets that are there to make it more possible for people to access that food, which was cut off from them before by the transportation system. And so I think there are many levels, not just but certainly in the United States, it is remarkable that people get very little time off, period, for recreation and just rest. That we are in a practically 24-hour work cycle with our handheld devices and everything else. A lot of us are in jobs where we're just connected all the time to work, which I think does make it more difficult to do things like prepare food at home and sit down and a meal with your family and some of the other nice things to do that actually are, and go out and play baseball with your kids, the things that help to promote physical activity and healthy eating. I think people are working instead of doing those things. I also frankly think that we may be working our kids too hard, but that's a whole other topic. But they are being pushed to, which is part of why physical education got pushed out of the schools. Part of it was money, but part of it's been a judgment that they need to be hitting the books more and earlier on need to be learning more vocabulary, math, whatever. And we just haven't valued activity enough, and I think that's just reflected across the society. And then you mentioned breastfeeding, and that's an ongoing concern. I think everybody in the pediatric community, where, it's kind of like with the obesity thing, we keep telling people, initiate breastfeeding, do it longer, right? And that's just as effective as telling people eat less, exercise more. If they don't get time off, if they don't have support in the workplace and the rest of the environment to actually be able to lactate, to continue to lactate, to feed that milk to their infants.
We have time for one more question.
Just one more comment. I'm so glad to hear about the nutrition and important of it's in the clinical practice setting, and how important it is to educate or give time to talk about the nutrition to your patient. But then one of the things I kind of see missing is the area that has been exploring and then coming out a lot is neighborhood food environment, and how access and availability of these healthy options in your neighborhood or the environment you live or work or play is important. And there are a lot of research that are showing that access to these available healthy options will lead to better choices, like dietary choices and better health options. But then the thing is, basically when you are thinking in terms of the clinical practice, and then the nutrition educator or someone who is kind of guiding the patients regarding how their diet should look like, or diet behavior, I think it's also important to think about the geographic areas you are working in, and thinking in terms of what advice may be really practicable in terms of what, I know it's easy to say that, okay, try more fruits and vegetables, but I think things that need to be concerned and be aware about is whether you have access to that in your neighborhood, in your geographic areas you are working or not. If not, then what would be the better options to go about it? Thank you.
Thank you. Yeah, I'm going to go for final comments, starting with you, Judy.
Yeah, so I guess just in a nutshell, my closing comment, I guess, would be that someone mentioned that nutrition was the poor stepchild of the clinical world, and I was at a meeting recently where the comment that kept recurring was exposure science is the poor stepchild of environmental epidemiology, and so again, I would suggest that in the spirit of collaboration that we, as we do these studies, we make sure that we're reaching out to exposure scientists. And the second point is that I would reiterate from Linda's comment is that we need to be really thoughtful about how we move forward with alternatives to current products, so that we aren't moving from a chemical about which we know a lot to a chemical about which we know nothing, and ultimately may end up being of greater risk. So we need to have a thoughtful process for dealing with alternatives.
Thank you, Judy. Jean?
Yes, thank you. I wanted to echo Judy's comment about knowing more about what chemicals we're recommending. As clinicians, we are relying on the research of the experts that we've heard for the last 2 days. We're looking for guidance to make the best recommendations both for the clinician and for the patient. So as much specific information as a powerful group like this feels is important to get across to us, then we can relay that more effectively. So I think it's coming up with some very conclusive examples of what clinical guidance we can provide is where we need to go.
Thank you. Sonia?
I'd like to come back to the balance between providing people with information to answer questions they may have, and then training individuals and especially parents to be the front line of defense for protecting their family. And I think every time I give out information based on what I see in the science and nutrition literature, I team that side by side with the idea that there are governmental institutions that are charged with protecting health, and that a lot of protecting people from chemical exposure has to take part in a more democratic way across our society through policy change. Because otherwise, I think we do really end up in a similar situation to counseling obese people by telling the parent that they are charged with protecting their kids from all these unknown and understudied contaminants, which really isn't fair and causes a lot of stress without a lot of health protection.
Thank you, Sonia. Sheila?
Yeah, I just have 2 comments. One is that I think that this is a really big multidisciplinary field, so to build on the past session, that we really need researchers to work together, but in the same vein, we need policymakers to work together to come up with comprehensive policies that address all the different aspects of obesity management in our society, not just the environmental exposures, but the other components that are not specifically addressed in this 2-day conference. And then I would echo Sonia's comments that it's very difficult to shift the burden to the individual. We try to do this on an individual level in counseling, and it is very, very difficult to do, and we don't have evidence to make the recommendations that we give to people. And to say that to a really scared parent is difficult on a daily basis.
Thank you. Lynn?
You know, I've been stuck here thinking about the federal situation, how we've had remarkable White House leadership in the issues of physical activity and diet. The First Lady has been so engaged, has brought so many people together, the agencies, foundations, industry, and it's made a lot of progress. And yet, the things that we've been talking about during the last couple of days have not been a part of that. And how to get these issues to the table and make that a part of the effort, and make people like CMS pays for a lot of medical care aware that there are probably cost savings that can be gained, and industry aware of this. And so it's even though there's been a wonderful, very broad effort, it needs to be broader. It needs to bring in more of the science. It needs to bring in FDA, EPA, others, to be able to assume their responsibilities in this, because you're right, it's not just about individuals and what they can do. And so, we have a ways to go before that. We have a policy framework that actually is addressing these issues.
Well, I'd like to thank all the panel members. In my own opinion, I'd say, we've initiated this conversation on policy. We are not quite there yet. We haven't talked about the cost part at all right now, but that's to come. The genie is out of the bottle. I think the trick is how we can either bring the genie back inside the bottle, which might be extremely difficult, but if we can make the genie behave to our commands a little bit more better, I think we will get there. And with that, Frank, a round of applause for the participants, and Frank to take us home.